Welcome to Wisdom Radio. I'm Dr. Rusty Hoffman, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started.
Today we're wading into the contentious debate in the world of oncology.
Oh, absolutely. It is the classic turf war.
Right. I mean, if you work in a hospital, especially if you spend any time sitting in a multidisciplinary tumor board, you know the vibe. You know that tension in the room. You've got the surgeon with the scalpel on one side and the interventional radiologist, the IR, with the needle on the other. And for decades, let's be honest, the hierarchy there has been pretty clear.
Clear and incredibly rigid. The narrative has effectively always been, if you can cut it out, you cut it out.
Right.
Surgical resection is the gold standard, and thermal ablation, well, that's just the backup singer.
The plan B.
Exactly. It was for the patients who were too frail, too sick, or had, too many comorbidities to handle the quote-unquote real treatment.
But we have a stack of documents today that suggests the backup singer might just be ready to take the lead mic. We are looking at the COLLISION trial.
Such a great name for a trial, by the way.
It really is. Published in Lancet Oncology in 2025. And honestly, looking at this data, game changer feels like an understatement.
It really does. I mean, this is the mic drop that the IR community has been waiting for years. For the first time, we have high-quality Phase 3 randomized controlled data comparing these two modalities head-to-head for colorectal liver metastases.
But we aren't just looking at the trial results. We're also going to dive into the how. Yeah. Because if ablation is going to become the new standard of care, the skill set required to do it needs to scale up fast.
It has to. You can't just flip a switch and expect everyone to have expert-level technique overnight.
Right. So we're also looking at a platform called Wisdom, founded by Dr. Rusty Hoffman from Stanford, which is trying to completely rewire how you learn these high-stakes procedures.
It's a two-part mission for us today. First, we validate the needle with the collision data. We prove the concept. Second, we figure out how to democratize the actual art of using it so every hospital can replicate these results.
Let's start with the history, just to sort of set the stage for you. Why has surgery been the undisputed king for so long? I mean, IR has been around for a while. Why the intense resistance?
It ultimately comes down to long-term survival data. Historically, surgical resection for colorectal liver metastases, CRLM, has shown 10-year survival rates somewhere between 18 and 24%.
Which is pretty solid.
It is. That's the benchmark everyone chases. But when researchers looked at ablation in the past, the numbers just didn't stack up. They frankly looked worse.
But there was a massive catch with those old numbers, right? It wasn't exactly a fair fight.
Oh, a huge catch. It was textbook selection bias. Think about it. In all those retrospective studies, they were comparing patients who were healthy enough for major open surgery against patients who were sick, frail, or had massive tumor burdens and could only handle ablation. Of course, the surgical group lived longer, they were healthier to begin with, and that is exactly what the COLLISION trial finally fixed.
So let's talk about the design. This was run out of the Netherlands, Belgium, and Italy.
Right. Very rigorous design. They took patients with small metastases defined as 3 centimeters or less.
And crucially, no extrahepatic disease.
Right, and this is the key part for you listening. These patients could have had surgery. That is the critical distinction here. They had a good performance status. ECOG 0 to 2. They were fit. They were entirely eligible for both the scalpel and the needle.
So they randomized them 1-to-1. Half got surgical resection, half got thermal ablation, mostly microwave ablation, I think some radiofrequency ablation early on in the trial. But it was best versus best.
Precisely. Best candidates, best treatments, no hiding behind patient selection excuses anymore.
Okay, so here is the dramatic twist in the story. They didn't even finish the trial. Now, usually when I hear a trial was stopped early, I assume something went horribly wrong, like severe safety issues or it just clearly wasn't working.
Yeah, that's usually the case. But this was the exact opposite. It was stopped for early benefit. The Data Monitoring Committee looked at the interim results and essentially said, we have seen enough. The proof is here. It would actually be unethical to continue randomizing patients into the surgical arm.
That is a bold move. So let's look at the scoreboard. The primary endpoint was overall survival. Did the needle hold up against the knife?
It was a dead heat. The hazard ratio was 1.05. To translate that, patients treated with ablation lived just as long as those treated with surgery. In fact, The median overall survival wasn't reached in either group because people were living so long.
So non-inferiority is firmly proven. If you're a patient, choosing the needle doesn't mean you're dying sooner. That's the baseline requirement to even have this conversation at a tumor board.
Precisely. But here is where the story shifts from a tied game to a potential blowout. We have to talk about the costs of the procedure to the patient.
And we don't mean financial cost here.
No, that's part of it. I mean, the physical toll, the morbidity.
The safety profile. I was looking at the charts in the Lancet paper, and the difference is stark. It's not even close.
Yeah. It is staggering. In the surgery group, 46% of patients experienced an adverse event. Nearly half of the people who went under the knife had a complication.
And in the ablation group.
19%.
Wow.
You are cutting the complication rate by more than half. The p-value was less than 0.0001.
And then there's the hospital stay.
Median hospital stay for surgery was 4 days. Median for ablation was 1 day.
1 day.
Yeah.
It's practically an outpatient procedure.
Essentially, yes. You walk in, you get the procedure, you go home the next morning. Compare that to 4 days of post-op recovery from a liver resection.
Yeah.
You're talking about freeing up ICU beds, reducing hospital-acquired infection risks, getting patients back to their lives faster.
And we haven't even touched on mortality yet.
Zero.
0%
treatment-related mortality in the experimental ablation group. None.
And the surgical arm.
In the surgical arm, it was 2%. Now, to be fair to the surgeons, 2% is very low. Liver resection is generally safe in expert hands, but 0 is obviously better than 2%.
So let's just recap the scorecard here for a second. Survival, equal. Complications, way lower with ablation. Hospital stay, slashed by 75%.
Right.
And mortality, non-existent in the ablation arm. It really begs the question, why are we still cutting these out?
That is exactly what the authors concluded. They explicitly stated in their interpretation, and I'm paraphrasing a bit here, but they said the assumption that thermal ablation should be reserved only for unresectable colorectal liver metastases requires reevaluation.
Which is academic speak for change the guidelines now.
Exactly.
However, and I want to play the skeptic for a minute here, the surgeon's advocate, if you will, because I know exactly what the surgeons in the tumor board are going to say to this. The knock on ablation has always been local control.
The old can you get it all argument.
Exactly. The idea is, sure, you burned it, but did you get the microscopic disease at the edges? A surgeon can open you up, see the liver, physically feel the tumor, take a wide margin and send it to the lab. An IR is working off a 2D screen. Did COLLISION address the recurrence rates?
They did, and this is where we need to get a little technical because the terminology here matters immensely for our listeners. The trial found local control was non-inferior, but that finding hinges entirely on understanding two concepts, R0 and A0.
Okay, break that down for us. R0 versus A.
So R0 is a pathology term. The surgeon cuts out the block of liver, sends it down to pathology, and they slice it up and look at it under a microscope. If there is at least 1 millimeter of clean, healthy tissue completely surrounding the tumor cells, that's R0. It means you got it all.
Okay, but an IR doesn't take the tissue out. The ablated tissue stays in the liver and eventually gets reabsorbed or forms a scar. So you obviously can't check it under a microscope.
Exactly. So IRs use A0. This is an imaging-based margin. In the COLLISION trial, they rigidly defined an A ablation as having a visible margin of at least 5 millimeters of ablated tissue surrounding the tumor on the immediate post-procedure scan.
Wait, so the surgeon only needs 1 millimeter of physical clearance, but the IR needs a 5 millimeter visual buffer on the scan to be considered safe.
Right. You need a much bigger safety zone because you're relying on imaging, not a microscope. And here is the brilliant insight from the trial. They found that when they actually achieved that A0 margin, that full 5 millimeter burn zone, it reflected the absence of local progression in 95% of cases.
Wow.
Yeah, that matches the clinical success rate of an R0 surgical resection.
So the biological outcome for the patient is exactly the same if, and this feels like a massive if you can technically achieve that 5 millimeter margin.
And that right there is the crux of the whole issue. That is the pivot point for the future of IR. The COLLISION trial results are fantastic, but you have to remember they were achieved in high-volume expert centers. These were operators who knew exactly how to position the needle, how to account for heat sinks near major vessels, and how to rigorously verify that margin before pulling the probe out.
And that's the art part of our title today. It's one thing to stand at a podium and say ablation works. It's another thing entirely to actually do it perfectly in a complex case. I mean, if you're a patient, you don't just want ablation, you want collision-level ablation.
Correct. Because if you miss that margin, if you leave even a sliver of tumor behind because you were too timid near a blood vessel, you've done the patient a huge disservice. They're going to recur. You might as well have sent them to surgery.
Which brings us to the implementation gap. How do we take the results from these expert centers in the Netherlands and replicate them in a community hospital in Ohio or a regional center somewhere else?
Textbooks aren't going to cut it. IR is way too visual. It's too dynamic. You can't learn wrist feel or how to interpret ultrasound artifacts from reading a PDF.
No. And the old medical model of see one, do one, teach one is, frankly, completely outdated for technology this complex.
Yeah.
Which is exactly where our second source comes in wisdom.
Yes.
This is the platform founded by Dr. Lawrence Rusty Hoffman from Stanford. And I think it's so interesting because it's framed as a gated community. This isn't just, IR TikTok where anyone can scroll through and post a video.
No, not at all. It's strictly for licensed healthcare professionals and verified industry members. It's designed specifically to be a safe, highly professional space. Dr. Hoffman's whole goal with this was to capture the nuance, the invisible stuff that usually only gets passed down at the bedside if you're lucky enough to do a fellowship at a top-tier institution.
They break the educational content down into pearls. Really love that terminology. It feels very authentic to medicine.
Yeah.
Clinical pearls.
These are short videos, always under 4 minutes, high impact, zero fluff. And they focus specifically on image-guided procedures. So let's tie this back to collision for a second. Let's say you have a 2-centimeter liver lesion, but it's located right up against the diaphragm. That is tricky.
Extremely tricky. You're worried about causing severe pain. You're worried about the margin.
Right. You definitely don't want to burn right through the diaphragm and cause a pneumothorax, but you still absolutely need that 5-millimeter A0 buffer we just talked about.
Exactly.
Now, in the old days, a community IR might just look at that scan and refer the patient to surgery because it's quote-unquote too hard. But on Wisdom, you can search for and find a pearl that shows you exactly how to perform hydrodissection.
Injecting fluid to push the diaphragm away from the liver.
Exactly, to create a physical safety zone. You watch the video, you see the actual ultrasound setup on the screen, you see the operator's hand position. It transfers the how-to knowledge almost instantly.
It's basically just-in-time learning. You're prepping for the case tomorrow, you watch the pearl tonight. It's a lot more practical than sitting through an hour-long PowerPoint lecture at a conference once a year and then trying to remember the steps 6 months later when the actual case shows up.
And beyond the pearls, there's another feature they built called morning rounds.
Yeah, explain that one. Because in a hospital, morning rounds are where the real raw learning happens.
That's exactly the vibe they recreated digitally. Morning rounds is a clinician-only space. Industry members, device reps, and the like are completely blocked from this part of the platform. It allows doctors to share difficult cases, show their complications, and ask, hey, what went wrong here? Or how would you handle this weird anatomy? Without any fear of judgment or someone trying to sell them a new catheter.
That separation seems so crucial. Industry can see the pearls, so they can see how their devices are actually being used in the wild, but they can't meddle in the clinical decision-making discussions.
Dr. Michael Jaff, who has a huge background in both vascular medicine and the device industry, pointed out in the source material that this is actually a huge win for device makers too. They get a fly-on-the-wall view of real-world usage via the pearls. But for the doctor, it's really about mentorship at scale. It's about not practicing in a silo.
Let's tie this all the way back to collision. We said earlier that the trial required expert consensus for a patient to even be enrolled. A panel of 31 IRs and 32 surgeons had to look at the scan and agree the patient was eligible for both.
Right. They excluded patients if the tumor was too technically difficult for one modality or the other.
So the art of IR isn't just sticking the needle in the right spot. The real art is patient selection. It's having the experience to look at a complex scan and say, you know what? I cannot get an A margin on this safely. This one needs a surgeon.
That judgment is the hardest thing to teach in medicine. You can teach anyone the mechanics of pushing a button on a microwave generator. You cannot easily teach clinical judgment. And that's what platforms like Wisdom are trying to convey through these peer-to-peer case discussions. It shifts the question from, can I ablate this, to, should I ablate this?
It really feels like we are rapidly moving toward a treatment-agnostic future in oncology. That seems to be the underlying theme of all the documents today.
Treatment agnostic is the new buzzword, for sure. Historically, oncology was incredibly siloed. You go to a surgeon, you get a resection, you go to an IR, maybe you get an ablation. The collision data is screaming at us to stop looking at the doctor's specialty and start looking at the tumor.
Right. If it's under 3 centimeters with no extra hepatic disease, the data says the survival outcome is the same. So the default question at the tumor board shouldn't be, can we cut it out? It should be, why wouldn't we ablate this first?
That is a shift in thinking. If you have a therapy that offers the exact same survival 0% mortality and lets the patient go home the very next day, the burden of proof really shifts to the surgeon. They now have to justify why they would subject a patient to a major morbid liver resection for a 2-centimeter lesion.
That is going to be a very awkward conversation at some tumor boards next week.
Well, it might be, but data drives practice. Or at least it should.
But again, and I cannot stress this enough for the listeners, that logic only holds up if the IR is genuinely good. If the IR is just okay, then the surgery might actually be safer in the long run regarding local recurrence.
100%. The data is only as good as the hands holding the probe. If we see a sudden rush of inexperienced operators trying to replicate collision without the proper training, without truly understanding the necessity of the margin, we are going to see recurrence rates spike. And then the narrative will instantly flip back. The surgeons will say, see, we told you ablation doesn't work.
So the uptake of these incredible trial results has to be paired perfectly with the uptake of advanced continuous education.
The needle is evolving to replace the scalpel in these specific indications, and digital mentorship is evolving to replace the old school local apprenticeship.
It is such an exciting time to be an interventional radiologist. You've got the Lancet paper in one hand to show the tumor board, and you've got your phone in the other hand to learn the exact technique you need for the case.
It really is. And for the patients, it offers hope for a much, much easier journey through a terrifying cancer treatment. Less time in the hospital, less physical trauma, exact same life expectancy. That is the holy grail of oncology.
So here's a final thought for you to mull over. If you are an IR, Collision is your new Bible. But it's also your biggest challenge.
Don't just read the abstract and take a victory lap. Look at the safety tables. Look at the strict margin definitions. And then ask yourself some really honest questions. Am I hitting that full 5-millimeter buffer every single time? Do I know how to handle the tricky anatomical locations?
And if the answer is maybe, or sometimes, go check out how the masters are actually doing it. The resources are out there now. Wisdom is there.
Indeed. It will be fascinating to watch the guidelines over the next few years. I suspect we are going to see a major rewrite as this data truly permeates the field.
I'm guessing a lot fewer 4-day hospital stays in our future.
That is certainly the goal.
All right, that wraps up our dive into the Collision trial and the Wisdom platform. Check the show notes for the links to the Lancet article. It really is worth a deep, thorough read and the link to Wisdom. That's all for today. Thanks for listening.
This is Dr. Rusty Hoffman, and that's a wrap for Wisdom Radio. Download the Wisdom app by searching for Medical Wisdom, spelled WYSDOM, or visit medicalwisdom.ai for rapid-fire videos, podcasts, and community insights. And remember, knowledge is the best medicine.